Good morning, everyone. Welcome to our August Journal Club for the National Centre for Antimicrobial Stewardship this year. This month, we are very fortunate to have our veterinary colleagues join us, and they'll be presenting on a range of topics and projects that are in the field of antimicrobial stewardship in the veterinary stream. So I will take it over, hand it over to Kirsten, who is one of our postdoctorate fellows and is hosting the Journal Club today. Thanks, Kirsten.
Thanks, Courtney. Just share my screen. Hang on a little. And then we'll start this. Is that sharing the first slide? Yep.
Yeah, it is.
Okay, so today we have three presentations. Laura Hardifelt and I, who are both veterinarians and postdoc fellows, that's come off a bit funny, we'll be presenting on a stewardship trial we ran in 135 companion animal veterinary clinics. Then we'll have a short presentation from Scarborough, one of our PhD fellows, on the power of social norms to change behaviour. And following that, we're going to have Adam Williamson, who is the Managing Director from Make Data Useful, and he's going to present on fast feedback loops, how we're transforming big data into agile benchmarking dashboards for clinicians and managers. So I'll get started. So successes and lessons, what happened when we implemented an antimicrobial stewardship program across 135 companion animal veterinary clinics? So just give everyone a bit of a background about veterinary antimicrobial stewardship. Essentially, back in 2018, when we started looking at doing our trial, there was no established model for developing or instituting antimicrobial stewardship programs in a veterinary setting. And in Australia, we have about 4,000 veterinary clinics. The majority of those, about 70%, are privately owned. And the general structure of a veterinary practice varies significantly. In your mid-sized practice, you've probably got a practice manager, one or multiple veterinarians, some nurses, and a couple of receptionists. And then you may have a sole practitioner, though, that may have the veterinarian that does the same role as the practice manager a bit. And then you'll have a nurse that's also the receptionist. So you might have only 2 staff members. And then we'll go up to some of the bigger referral hospitals or specialist hospitals that will have more staff. They might have specialists in medicine and surgery and emergency, as well as neurologists. They might have their own imaging specialists, and they might function more like more similar to a human hospital. Today, we're focusing on general practice, though. So these are the main staff members that would be in a practice. And we don't actually have, in Australia, we don't really have any mandates or legislation to enforce antimicrobial stewardship. They are starting to come, but we really are looking at motivation rather than sticks. Looking at that, so I said there were no templates, if you want, for introducing a program. And so this is just a summary of some of the literature that is really just coming out now. So the first paper about implementing a stewardship program came out in 2019. And this is a Dutch study, and this was across 44 different practices. And it was a reasonably involved program with some self-evaluation of prescribing and some feedback and some educational resources. Then a university practice has come up with quite a detailed stewardship program based on the CDC's 7 elements of an antimicrobial stewardship program. But this paper was more just presenting, this is how you could do stewardship, rather than this is how we did it and this is how it worked. Then there's this British paper published in Nature Communications that really focused on, I guess, sort of social nudges and informing clinics that they were high prescribers of critically important antimicrobials, and then giving them some feedback on their prescribing over time to try and change a subset of their prescribing. And then this year, this paper came out, which was essentially they did an audit of prescribing across a 9-branch practice and had a few seminars where they presented those findings, discussed the guidelines that are available in Britain, and then came up with their own guidelines. So it was a fairly a one-off intervention. Because of the different types of veterinary practice in Australia and they're private businesses, we don't have all the different specialities that a human hospital has. Definitely one size does not fit all for implementing a stewardship trial in veterinary medicine. And so we recognised this, and so we had to adapt it to socioeconomic and personnel factors, and we wanted buy-in to the strategy. So we identified that some of the practices needed to start at a lower level of intervention in the first phase of this trial, and so although we hoped to have it randomised to start with, we ended up having to reallocate some of the practices. So Green Cross Vets is one of the largest corporate veterinary groups in Australia, and they had 152 general practice clinics at the time we started our trial. And we excluded some that there was some flooding in Queensland that meant that some of the clinics were under a fair bit of stress or were closed, and for various other staffing reasons. And so we had 135 general practice clinics that we initially did a random allocation to the different programs, but then we had feedback from the regional clinical directors that they didn't think some practices would be able to cope with that, and so they got reshuffled around. So in our trial, we had 3 different programs. We had a control group, AMS1 program, and AMS2 program. Looking at what those programs entailed, in yellow at the top, we have the interventions that were in the control group. So I guess technically it's not a control group, but they were fairly minimal. So we essentially provided a prescribing guideline poster and a series of 7 educational webinars. The next program, the AMS1, they had the same access to the same guidelines and educational webinars, but they also were required to appoint a stewardship champion, implement a traffic light system, which was essentially to colour code their antimicrobials in the clinic pharmacy based on their importance rating, with green for low, orange for medium, and red for high importance. They had diagnostic testing guidelines. So for a cat with a urinary tract suspected urinary tract infection, they needed to do cytology or submit a sample for culture and susceptibility. But these guidelines they could tailor themselves to what they thought was reasonable, and they needed to incorporate AMS in their staff induction policy. The AMS2 group had all of the interventions on the screen. So in addition, they had local prescribing guidelines. So on the poster, there was space for them to write in the details of what their practice policy was going to be. They were to undertake antimicrobial resistance surveillance, restrict critical antimicrobials. So this meant that any antimicrobials that were rated high importance by ASTAG, they needed to seek permission before they used them. Which, as I mentioned, we have some sole practitioners. So in that instance, we recommended that they had to contact their regional clinical director to get approval. Audit and feedback was to be undertaken, particularly for new graduates and new staff members, by the senior veterinarians within the first few months of them starting, and the use of delayed prescribing. The trial started, we circulated the materials needed to implement this in October 2018. And then it took, with such a large group of practices and there's different levels of management, we created this implementation phase because it took a while for it to filter through to the practice managers and the veterinarians in the clinic. We also looked at a pre-trial period of antimicrobial use data from 2016 to 2018. And then we have our post-implementation phase. So after we felt that everybody had received the materials and started using them, then we looked at their antimicrobial use after that. So what happened with the trial? We've analysed it in 3 ways, and we're only going to present 2 of those today. So we did a survey of the veterinarians that participated, and we did an antibiotic use analysis, which Laura is going to present. And one of our master's students, Susanna, also conducted interviews of vets, nurses and practice managers to get a bit more information on what the challenges were and what the successes were. So we had survey responses from 267 vets, which were from 108 clinics. So there were 135 clinics in the trial. So we felt that we got a representative response. And 2 out of 3 vets thought that they had an AMS program, which, given that there was essentially the control program, which was a poster and some webinars, we thought that was reasonable, although it didn't correlate exactly to which arm of the trial they were in. Overall, 43% appointed an antimicrobial stewardship champion at that practice. And in the yellow, purple and blue, you can see the breakdown by program type. So a champion was only part of AMS 1 and AMS 2. So it seems like it's a natural progression that if you're going to have a stewardship program, that somebody's going to be the leader. And of the people that had a stewardship champion, 86% agreed that the champion was an effective advocate for appropriate use of antibiotics in their clinic. With the traffic light colour code, here's some photos of the veterinary pharmacies where they've highlighted the drugs, the barcodes on the shelves, or they've put coloured dots. 36% of vets implemented the traffic light system. This time we had higher uptake in the 2 programs, which this was a part of, and 71% of respondents thought this changed their prescribing approach. With delayed prescribing, 59% of vets said they used delayed prescribing, and we had, again, we had fairly even uptake across the 3 trial programs. And of the people that said they use it, 90% said delayed prescribing was a useful way of reducing unnecessary antimicrobial use. We did create a form for vets to use for delayed prescribing, so they could give this to the pet owner in the consult with some things that the client could do at home with their pet, some details on what to expect for how long it would take the animal to recover and when to come back if it wasn't improving. We don't unfortunately have data on how many animals actually received the handout. We suspect a lot of veterinarians use this in a more informal way, where they sort of describe it as a delayed prescription rather than actually handing one out. And now I'm going to hand over to Laura so she can talk about the antibiotic use analysis of the trial.
Thanks, Kirsten. So we were lucky in this trial that Green Cross contributes their data to a big database called Vet Compass Australia. So all of their prescribing data from all of their practice goes into this database, which is run by all of the vet schools in Australia. So it's a collaboration between all the vet schools in Australia. So we were able to get the data from there. We were also lucky that we had a PhD student, Brian Herr, who some of you may have heard speak before, who is a computer scientist and a veterinarian who worked on the back end of this data and made it got it into a useful format for us. So Brian did his PhD on natural language programming, processing and machine learning using the Vet Compass data. And so using some of Brian's algorithms, we were able to extract all of the consultations, the antimicrobials, select only the systemic antimicrobials rather than we excluded the topical antimicrobials and all other routes apart from systemic, and then do some useful statistics on it. So we did some descriptive stats where we looked at the proportion of antimicrobials prescribed. We also looked at the high prescribing practices, and they were defined as those in the top 25% of antimicrobial prescribers in the pre-trial period compared to all other practices. And then I did a +1 regression model as well. So we'll take you through some of the results now. So of the 135 clinics enrolled, on average, there was 1 to 9 vets per clinic, and there was a big range in the rates of antimicrobial prescribing between the practices. They ranged from as low as 1 to all the way through to around 8 prescriptions per 100 consultations, but the data was skewed. So around 90% of the practices prescribed less than 5 antimicrobials per 100 consultations. In the whole data set, so for the 4 years of the trial, we had around 8.5 million consultations and about 250,000 systemic antimicrobial prescriptions. And unsurprisingly, 8 antibiotics accounted for the bulk of the prescriptions. And these are, really constant numbers around the world and pretty consistent with what we see in the medical sector as well. So amoxicillin clavulanate was by far and away the leader of the pack, but cephalexin and then metronidazole and cefavecin were also really commonly prescribed. So this is what happened in the sorry, Kirst, can you go to the next slide, Kirst?
Yeah, sorry.
Sorry, yeah. So this is what happened over the period of the trial. So in the pre-trial period, the incidence rate of prescribing was 3.7 per 100 consultations. In the implementation phase, that reduced to 2.4, and in the post-implementation phase, it reduced to 1.9. So we had a 50% reduction in prescribing over the period of the trial. What I will say is that in the pre-trial, in the 2 years of the pre-trial period, we did already see a 13% reduction. So there was already in that period before the trial a reduction in antimicrobial use, but it certainly was sped up over the trial itself. If we look at what happened within the groups, it's quite interesting to see what happened when we look at these antimicrobials as low, medium, and high importance rated. Encouragingly, we saw an increase in the proportion of low importance antimicrobials used across all groups, but that was statistically more in the most intensive group in AMS2. And in AMS, in the medium importance rated antimicrobials went down in all groups. So we got people to use more of the low importance and less of the medium importance rated drugs. And again, there was a statistically significant difference between the control group and AMS2 in this. When we looked at the high importance rated antimicrobials in the control group, which is the solid line, they went from 15 up to 20% of all antimicrobials used were the high importance rated antimicrobials. And this is really Convenia, which is a 3rd generation cephalosporin, accounted for the bulk of this high importance rated use. Whereas in the AMS1 and AMS2, we saw a steady kind of neither an increase nor a decrease. And that was statistically significant. So in AMS1 and AMS2, we did see a decrease compared to control. And it's really Convenia or cefavecin is a long-acting 3rd generation cephalosporin, and it is marketed for its convenience, particularly for use in cats. And so there's some really strong drivers, which obviously we weren't able to address in this trial, and it's something we probably need to think about more going forward. If we look at the high prescribing practices in all arms of the trial, so the panels on the left are the high prescribing practices, and the panels on the right are all other practices, the bottom 75%. And in all arms, control AMS1 and AMS2, we saw that the difference is statistically significant. So we had about a doubling of the reduction in the incidence rate of prescribing in the high prescribing practices compared to all other practices. And, it's if we think about why that might be, it's possible that it was, given that the prescribing was much higher in that group, that there was much easier low-hanging fruit that they could tackle. But I think also that possibly these practices were identified as being high prescribers by the regional clinical directors and by the management, and had a little bit more effort put into implementing the trial. And hopefully some of that will come out in Susanna's work as well. So overall, I think we had a really positive impact with 3 different stewardship programs in this large group of general vet practices. We saw an overall decline in antimicrobial use by about 50%, a shift towards the use of low importance rated antimicrobials, and the greatest impact seen in high prescribing practices. So what's coming next? So we're now introducing a consolidated program. So we've taken what we learned from the survey and from the quantitative analysis, and we've come up with a consolidated program that we're going to implement in all practices, and some antimicrobial use benchmarking, which we're going to talk to you, we're going to talk a bit later about. So I'll hand back to you, Kirsten.
Yeah, so for our consolidated program, we've got core components that we want all practices to have, which is to appoint a champion, to implement the traffic light system, and obviously to have prescribing guidelines and follow them. And then we've got some recommended additional components, which would include the development of local prescribing guidelines. So we think this is a really great way to get people more engaged with guidelines, because I'm sure a lot of people recognise that having guidelines and using guidelines are 2 separate things. And so we're trying to get practices to have a meeting and go through the guidelines and work out what their practice guideline is going to be, and populate that on the poster to get the conversation started and really get people engaged. Obviously, people were already using delayed prescribing, and so we want to encourage them to continue to do that, and also to do it in a more formalised way, and to use diagnostic guidelines. So these were the guidelines for when specific diagnostic tests should be used for specific scenarios. And we're planning on, we're rolling that out in the next few months. They have a big symposium in October, which will give us an opportunity to present these results and the consolidated program to a large proportion of the clinics all at once. So that's the end of this first section of the presentation today. There's quite a lot of people to recognise that have helped with this, particularly all the staff at Green Cross, but also Vet Compass. We couldn't have done this work without them. And Brian Herr played a very integral role in database curation and natural language processing, and Susanna, amongst others. But I'll move on so that we can get to the next talk.
Thanks, Kirsten and Laura. We just, before moving on, we might allow just for some questions. So thank you both for presenting all that work. It looks like it's been a very busy time for all of you. I guess I'll allow people to use the Q&A or chat feature to type in any questions that they might have. But I guess I had a question about the diagnostic guidelines. To develop those, is that more like a consensus-based thing, or there is just quite clear evidence of when to order tests? It's just that it's not being done, or like?
Yeah, I guess because veterinary practice is there's no Medicare, so the client pays for all the tests that are done and the medication. And so it does become a discussion about finances sometimes. How much money are we going to spend on diagnostics? And so this is trying to set a practice standard that in these situations, we are going to push strongly to do these tests. In an ideal world, we would do them all the time, but it's not as straightforward as that. If susceptibility testing was subsidised, perhaps that would be an option to do it in every single case, but it adds significantly to the cost of treatment for an animal. And so unfortunately, it may only be used in cases where there's recurrence, that it didn't respond to empirical treatment. So we had some guidelines, perhaps Laura can speak to this, for I think cystitis and some dermatology cases. I can't remember what the other scenarios were.
Yeah, so there are some international guidelines that do have some diagnostic testing guidelines within them for urinary tract infections and for superficial and dermatitis. So there are some that are a little more clear cut, but the rest are more consensus. So.
Kaz has asked a question. Yeah, you go.
Yeah, so Kaz asked if we found any difference in prescribing behaviour between cats and dogs beyond cefavecin. And actually, Kaz, we didn't in this study, we didn't break down use between cat and dogs. But it's certainly something we could do. There definitely is differences in prescribing between cats and dogs, and based on species differences. But it's not something we looked at specifically in the evaluation of the interventions.
No worries, thank you guys. There was just a question on the Q&A just about availability of slides, but so all our journal clubs are recorded, and they'll be on the NCAS website for you to re-listen to within a week. There is another question. The role of an AMS champion in this space is interesting. What were their tasks, or what were they to do as an AMS champion?
They were to, I guess, lead the way. So to ensure that the AMS interventions were implemented. So put the guideline poster up, ensure that the traffic light colours were put up in the pharmacy. They were also, there's an online veterinary AMS course which has a number of modules, and so the stewardship champion was to do that training. And they were the ones that were to lead any audit and prescribing, audit and feedback of prescribing, making sure it was, I guess they were sort of overseeing. And I know that in hospitals there's an AMS committee or a group, a working group. We just don't have the staff in a veterinary practice, so it sort of falls to, this is sort of like the mini committee, it's just one person. Maybe in some of the bigger practices there might have been a couple of people working together as a team. For the training, it was the modules were put together by all the veterinary schools in Australia. No committee in general practice either. Yeah, there's some similarities between veterinary practice and general practice.
Excellent. Thanks so much, guys, and thanks for all your great questions. We'll now move on to our next presenter.
To figure out my screen sharing. Is that showing the presenter view, or does that look good for you?
No, you're right, Ray.
Good. Okay. So I'm Ree Scarborough. I am doing my PhD. Kirsten and Laura are two of my supervisors, and I'm really interested in the human behaviour, I guess, of prescribing. And one of the things that interests me is the power of social norms information to change people's behaviour. I am by no means an expert, but it's a really interesting topic, and I think that no matter which field you're in, it is a good thing to know about. So I'm just going to present something about a systematic review that came out a little while ago. So the question is, what are the ways we can change people's behaviour? Some examples of some behaviours we might like to make happen at the AMS space are withholding antimicrobials where they're not clinically indicated, clearly recording indication, and Laura can attest to the fact that in the veterinary records, and I'm sure in some medical records for the other people online, it's not always clear why antimicrobials were given. We might want people to start using culture susceptibility testing to select their antimicrobials. We might want them to use a narrower spectrum antimicrobial, use the optimal dose, route, frequency, and use this shortest effective treatment duration. But how do you do that if people are not already doing it? I guess the classic operant conditioning says you either reinforce something to increase a behaviour, or you punish to decrease a behaviour. So like Kirsten was saying, this is about carrots and sticks, and you can either add a carrot or remove a stick to reinforce a behaviour, or you can add a stick and remove a carrot to decrease a behaviour. This, I guess, way of thinking about behaviour and influencing other people's behaviour is a little bit of it's more of a high maintenance way of doing things, I guess, because it requires someone to do the monitoring and to do the sticks and the carrots. So the question is, how else could we change someone's behaviour? And here are some thoughts that a lot of people have. Most people think they're better than average at their job. I think a lot of clinicians would say they like to think that they use evidence to guide their practice. They like to think that their colleagues would approve of the way that they practice, and that experts would also approve of what they do. And they often, when in the vets that we've spoken to, a lot of them look up to specialists who have presented and say this is what they learned from the specialist. They like to copy what the specialists do. So the expert approval is important. And they like to think that they do the right thing generally. Most people don't go to work to do a bad job or to do the wrong thing. They all want to do the right thing. So the importance of this is that people like to have a positive self-view, and they have a desire to conform to in-group norms. And so if you want to use that to change the behaviour, you need to link these thoughts to the target behaviour. So an economist from Oxford, Paul Collier, said most conduct is actually guided by norms rather than by laws. And I think regulations falls into that category as well. Norms are voluntary and they're effective because they are enforced by peer pressure. Strangely enough, for an economist, he didn't mention the other feature of norms, in that they're very cheap. And we would have seen that all of us have been exposed to social norms, behaviour change strategies, I guess. This is what your power bill might look like to tell you how you're going compared to your neighbours or people in your area. This was a New Zealand campaign to discourage binge drinking. And a lot of people in the room would have seen the Dame Sally Davies letter that was sent out to high prescribing GPs prescribing a high percentage of antibiotics. Sorry, a high rate of antibiotic prescribing. And so these are all ways that people have tried to influence behaviour using social norms, and that desire to fit in and be doing the right thing and to be seen to be not at the bottom of the pack at the very least. So the question is, do social norms actually work on prescribing? And there was this systematic review recently from Sarah Cottrell. So the question was, are social norms effective in encouraging health worker behaviour change? And what are the most effective types of social norms interventions? And the good thing about this systematic review is that a lot of it related to prescribing behaviour. A lot of the studies that were included in this review were actually about prescribing behaviour, and a lot of the ones about prescribing behaviour were actually about antimicrobial prescribing. So what can we learn from this? So there were 106 trials included in this meta-analysis, systematic review meta-analysis, and 43% of all the participants in the studies were primary care physicians, 18% were secondary care. There were no veterinarians, which is not much of a surprise. And the primary outcomes they studied were at a 6-month time point the closest, and 38% of them looked at the prescribing mostly of antimicrobials at that 6-month time point after their intervention. All of the trials were classified by 5 features that the authors decided were important, or 5 common features. The first one was social comparison. So just letting people know how they compared with their peers in terms of prescribing. The examples on the right are my own, just to give us a bit of a flavour for what we might use them for. Then information about what other people think about the behaviour. So, for example, 95% of your colleagues say that giving antibiotics for a particular indication is not acceptable. Then there was this concept of credible source, and that's a little bit like the general practitioner vets looking up to the specialists. And it might be infectious diseases professor says giving antibiotics for this condition is doing more harm than good. Then there's a concept of giving a social reward as well. Congratulations, you had the lowest prescribing rate of antibiotics in the country, for example. And then finally, the social incentive, actually telling people that you will give them something good if they do what you would like them to. So you could, for example, say the clinic with the lowest rate of antibiotic prescriptions for some indication which they shouldn't be using antibiotics for might get a team lunch. That's the kind of thing that might be involved in a trial, in an intervention like this. So the meta-analysis forest plot revealed that social comparison by itself did have an effect, but it was pretty small, and it was a positive effect. But there were 3 types of social norms interventions they found were most effective on average compared with the control groups. So the first one was social comparison and social reward. I would note that there were only 2 trials that had these features according to the authors, but that seemed to have a strong positive effect. Then the credible source, there were 3 trials that had an effect there, and the social comparison with prompts and cues. So I also noted that the p-value was quite high for that. But the conclusions of this study were that social norms interventions are effective in changing clinical behaviour in a variety of contexts, but the result was modest and quite variable. But the point is, I guess, that because this is a cheap way of changing behaviour, you can scale it up relatively easily, and then the overall effect can be quite powerful, which leads me into what are the most promising social norm interventions, I should say. It did look like social comparison with social reward would work the best, social comparison plus prompts and cues, and maybe credible source. So these are all things worth trying in the veterinary space and possibly in other spaces as well. So I would like to now hand over to my friend Adam Williamson from Making Data Useful, because I think the stuff that he's going to talk about is very relevant to what we're trying to do in just using that little bit of peer pressure, that positive self-view, trying to fit in with the crowd in order to have a positive effect on a large number of clinicians at the same time. Adam, would you like to, I should stop screen sharing.
Great, let me go ahead and screen share. Hello everybody, I'm Adam Williamson, Managing Director of Make Data Useful. So I was tasked with looking at the data, understanding how do we start to bring that to life and enable clinics to understand their performance when it comes to antibiotic prescribing. What I'll do is I'll quickly kick off with a little bit of a screen share about who I am, who my company is, and the approach we took to the problem statement. So we make data useful. We're expert data scientists and analysts. We're a small team based out of Melbourne, and we basically focus on the important things. We basically focus on analytics to enable people to get back to the important things. Our client groups involve sort of government, healthcare, defence, banking, sort of telco industries. And so we're really excited to be able to start to analyse some vet clinic consultation data. And I'll take you through what that actually is. So we're lucky enough to work with the Vet Compass database, so that we actually got a sample of 150 clinics which had over 500 uniquely identified drug billing line items that we were able to translate into their antibiotic ingredient groups, and then also incorporate the WHO and the ASTAG ratings as well around high importance, medium and low. For the sample set that we had, this actually resulted in over 300,000 consultation records that unlocked the ability to determine antibiotic prescribing habits across all 150 veterinary clinics. So this was really exciting for us because it unlocked the ability to not only show the total performance of 150 veterinary clinics, but also bring it down and make it real for an individual clinic and see how they're performing in comparison to their peer groups, whether it be by state or clinic type. And it kind of goes back to what Ria was just talking about there, where it's that social part as well. The Vet Compass data, it was completely de-identified, but we did get access to things like who the clinic was, a unique identifier of that consultation, the patient ID, which in this case was cats and dogs, the age, the sex, the drug billing line item, which I talked about briefly, and also the breed as well. So these are all really important factors that go into building out some sort of analytics and dashboards, which sort of drive that identifying what is the prescribing habits at the clinic level. There was some challenges with the data, as you've all probably experienced working with any type of data. For example, the billing line items were all very specific, down to the milligrams and milliliters. So we took the time to translate all that information into what is the ingredient translation, along with that ASTAG and WHO rating as well. And then we sort of started thinking about what are some of the metrics or sort of interesting insights that we can gather from this information. And we
Sorry,
landed
Adam, could you just make it a little bit bigger, just because I know you've got it in a PDF format? Yeah, now I can't see the full. Yeah, maybe just a tiny little bit smaller. Yeah, that's it. Yeah.
Okay. Awesome. So we've got the antibiotics per 1,000 consultations. So this attempts to put everyone on an even playing field in the data and make sure if you've got 1,000 consultations or 10,000 that it's an equal measure between the two. Then we have things like of the antibiotics that were prescribed, what percentage of those were of a high importance as far as the ASTAG sort of ratings concerned. What's really cool about that is it means that not only do we look at the 1,000 per consultations, we look at the ASTAG rating, and we can start to build out some scatter plots as well. What I'll do is, rather than just show you pictures of the dashboard, maybe I'll go ahead and I will share the actual dashboard. We've got two available today. So we'll start with a dashboard that is more geared towards, in this particular example, maybe a state-based sort of leader that wants to understand the microbial prescribing habits for each of their clinics within their state, or even at the national level as well. So first we start off with the overall number, which on average for the clinics that we were looking at for the date range that we had the data for, we had 41 antibiotics were prescribed per 1,000 consultations. And as you can see here, it's a little bit higher in cats. As I start to click through, for example, New South Wales, we can see here it's quite equal for cats and dogs, but a little bit higher than the other states. And as I work my way down, you can start to see how the numbers differ between the different states. And this can be really powerful, especially for these larger organizations like Green Cross we have here, who want to understand at a national or even state-based level their performance. We only had 3 months of data for this particular analysis, but we are excited to be able to work with Vet Compass to get a broader range of data as well, to look for those things like seasonal trends and start to understand what are some of the influences of the performance. Here we have a clinic view, and again, this would be geared towards sort of either, if I click on, say, New South Wales, a state-based sort of view to enable, okay, how many consultations per this de-identified clinic, what is the antibiotics per 1,000 consultations, and how many of those were of high importance, and then obviously the high importance percentage. So any good dashboard is going to allow you to look at this at a glance and get a feel for where are the opportunities of the high prescribing habits, and to dig deeper and understand a bit around the why. Down here, we've got a bit of a work in progress, but this is something that we've been playing around with. So the great thing about dashboarding and analytics, we get to iterate, we get to test things. So this one here, we've come up with this idea or concept of an antibiotic score, where we basically almost arbitrarily provide rating of 3 for a high, 2 for a medium, and 1 for a low. Sum them up, and you kind of end up with this ranking system that starts to think about, well, are you a high prescriber of antibiotics, and are you also a high prescriber of sort of a high antibiotic? So this one here, 102, does have a high volume of consultations and quite a high antibiotic score, and they rank sort of number 1 on the list of antibiotics per 1,000 at 83, which is quite a bit higher than sort of the overall average, which is sort of 41. The next thing we did is we had a look at what would it look like if we started to plot some of this data. So get a feel for state-based, whether there's some interesting things around species, and then eventually the clinic as well. So the two things this looks at is on the y-axis, we have the antibiotics per 1,000, and on the x-axis, we have what is the percentage of high importance. And this makes a bit more sense when we scroll down a bit further, where we've sort of drawn a couple of bounding boxes to get a bit of a feel for which clinics are sort of landing in that upper right quartile or area here, where we're starting to see, well, there is quite a high prescribing habit, and there's 102 again. The size of the circle, the marker there, actually indicates the number of consultations, so the volume's there as well at 5,000, and what percentage of those are actually high. Now, this is all good and well, and this is great for any sort of management team or a leader that's looking at this from a state or national level, but what does it mean for the actual clinic themselves? So we've started playing around with this concept of a clinic dashboard, which I'll share now. It's this one here. And so the clinic dashboard starts to bring together, again, how am I comparing to people within my state or national? And here I've just hit the drop down and selected 102, just that's the one we've sort of been looking at. And I'll work you through the different views we have. So the first one is, what is my prescribing rate per 1,000 compared to the state and the national sort of view? And you can see that here. What antibiotics am I actually prescribing from an ingredient perspective? Here's a bit of a rank to understand that. Here's my sort of prescribing habits over time. And again, we only had a 3-month sample here, but this is going to really come to life when we start to bring in maybe a year's or more worth of data. You can see here that they are quite a bit higher again than the state and national. How does my clinic compare when it comes to the AS tag, high importance, medium, sort of, and low? And how does that compare to the state? And our most sort of recent iteration on this particular view is, how does my clinic compare to all the other clinics? So this is the same view we saw just a moment before, but this then de-identifies all the other clinics and sort of plots my clinic in amongst all of them, which basically means that I can see at a glance that I am in that sort of top upper right. So I've got a high prescribing, and my importance is quite high as well over to the right. And you can see where I land amongst everybody else. With all of this sort of stuff, you've obviously got your date range sort of filters as well. And as we continue to iterate, we'll be bringing in more functionality around filtering and digging deeper into the data and understanding a bit around the why as well. Thank you, Ree. That was the clinic dashboard.
Fantastic. And yeah, given the information from the meta-analysis, perhaps there's an opportunity for us to provide some social reward or some feedback to some of the clinics over time if they improve their prescribing according to our metrics. And that doesn't necessarily need to be much, except to tell them that they've done a great job. When they log in to see their clinic dashboard, to see that they've done better than their last quarter or whatever it is. So those are things that we are excited to play around with in the future, in future iterations. But I think as it is, it's an amazing resource, both for the clinics involved, but also for us as researchers for things like monitoring the impact of the updated package of interventions that we're doing with Green Cross clinics based on the trial. So we'll be able to use those dashboards to help with that as well. Kaz asked a question. Is there an appetite to go to prescriber level feedback, a common request in NAPS? Great question. At this point, I think the answer to that is we actually don't have access to prescriber level information from Vet Compass at this point. Is that a fair comment, Laura? And so, yes, it is aggregated at the clinic level. Yeah, I'm not sure. I'm not sure whether we can get to prescriber level feedback at some point, but that would be interesting and good. Although I think in a lot of these clinics, people know within their small group who is kind of doing what. So often when we speak to vets, they know that there's someone who just really, really likes cefavecin injections. So that, you know, that often might be able to pick out where their areas are, you know, who is actually responsible for some of the more problematic choices in the clinic. Whether they can do something about it or not is another question. But did you want to add anything, Kirsten?
No, I think that covers it. Yeah, obviously we would like to get there at some point, but I don't think it's achievable at the moment just because of the way the data is collected.
There is an issue with the veterinary profession at the moment getting increasingly, there's a lot of locum work and a lot of change in the clinic staff in some of these clinics as well. So it is a little bit tricky sometimes to follow what individual prescribers are doing. And there's no, unlike in human medicine, there's no prescriber number because we have PBS or MBS. So it's a bit hard to kind of track what people are doing if they might be working in 10 different clinics. And it's a bit difficult to know.
And Kaz asked if we engaged clinics in the design. Be a great initiative, great to see it in human GP practice, and we do plan to, Kaz. So once we have a benchmarking platform that we can take out and get some feedback on, then we will engage in more of a co-design process and make sure the metrics are right and the presentation is right before we roll it out, for sure.
So,
Yeah.
So what Adam presented has not been implemented yet? No.
More of a proof of concept at this point.
Excellent. And
but
how
it
did
is
you get to that point? Like, I guess, did you guys approach their group, or was it Vet Compass? I guess, like, you know, for those in the GP space or other spaces, to how to try and get something like this happening.
Well, it was pretty organic. I think it was me talking to Adam for a cup of coffee one morning about, wouldn't it be cool it'd be so cool, we've got this access to this really interesting data, but it's quite hard to work with. And actually Adam and I previously worked on some letters similar to those ones that Dame Sally Davies did in the UK and that we had in Australia as well to GPs. But it was very cumbersome doing it as a one-off analysis to figure out who were the top 10% prescribing clinics and then sending them out a letter with an individualised report. And so it grew from that, really, like, how could we make this more scalable, easier to use, and easier for different groups to use as well. And also real time, you know, that's the other, it's virtually going to be real time once we roll it out, which is, I think a lot of people, it's hard to get to that level of quick feedback. And I think we're lucky in the veterinary space that there's fewer concerns around privacy. Most people don't mind you knowing whether their dog got amoxicillin or not. But yes, so we appreciate it's not as easy perhaps in some other fields, but we're really lucky in this space, and it's great to have Vet Compass and to have Make Data Useful help us with the Compass stuff.
Excellent. Thanks, Ree, for explaining that. I've got another question in the chat for Adam. So Nadine says, awesome presentation. How can data be cleaned if it's real-time data? Would data cleaning be going on in the background at the same time?
Yeah, that's the plan. So there's a few different approaches to cleaning the data. So the good news is we are using billing line items rather than sort of patient notes. So patient notes is extra messy because it's completely freehand, things are misspelled. Whereas billing line items, once we've got a good catalog of those, there'll be smaller and smaller fallout. So the idea behind that is to have a small bucket of other and then to continually update that data. And there's two approaches to that. One is a big long list of if statements. If it contains this word, this word, this word. But I have got some data scientists in the team that are itching to use some natural language processing to do some cool machine learning on the data as well.
Awesome. Thank you, Adam. There's no other questions in the Q&A. There is another question from Kaz though for our vet colleagues. Will you guys be incorporating Brian's natural language processing work into this?
A lot of Brian's natural language processing work underpins a number of the translations that we've already been able to get hold of, and I've actually got the source code of that work as well. So we've had conversations with Brian in the past about that, and we'll continue to, if we're available, leverage his expertise.
Excellent. All righty. Well, we've done very well for time. Thank you so much, everyone. We had, I think, at one point about 50 people joining us today. So a great turnout online, especially early in the morning. Thank you to Kirsten, Laura, Ree, and Adam for presenting all their work today. It's been really interesting to see not just us talking about AMS, but how you've developed, implemented a program and how behaviour change underpins all of that, and then how we can use that information to then use that data, make it meaningful to our clinicians and present it in a way to help further generate positive change. Well, that's the goal. So watch this space. I don't know if Kaz is available online to have any other further comment. I'll give her a chance, but otherwise, thank you all. And next month, the topic, it is Sepsis Awareness Month. So September, we will be talking all things sepsis, and Kaz will be hosting that session. So hope to see you all again in a month's time.
A tour de force as usual from the team. It's fantastic. I'll be doing a few tweets this morning, FYI.
Yeah.
Thanks, Kaz.
Thanks, Kaz.
Thank you, guys. Bye.
Bye.